you, Aris. And you are away, I'm away. I'm forced to be away. I'm sorry about it. A sudden problem with the back pain forced me to be away from you. But I'm very glad that the Congress is going very well attended. And I'm glad to participate at least online. So I start the presentations on the tricuspid valve with tricuspid tear, which is edge-to-edge repair, transcatheter edge-to-edge repair. But like many suggest, we should change this terminology and we should say body-to-body repair, because with these clips we don't just bring the edges together, but a large part of the body of the leaflets, we bring them together. Anyway, this is under discussion whether we should change this terminology. And when we are talking about clips, it was the only available transcatheter therapy practically till a few months ago. And then suddenly we have the first transcatheter valve, the Evoke, that is now available. So it's not the only kid in the block, the clipping, anymore. But this is the most widely available, and I'm sure it will be very widely available for the coming years. I don't think it will ever become like a secondary approach. Disclosures and the heart-in, we're working together at the year. So what we have for the tricuspid valve, we have the TriClip and the Pascal. The TriClip is both FDA and CE marked. The Pascal is CE marked for now. And we have the Intrepid, which is both CE marked and FDA approved. And we have the heterotopic tricuspid valve replacement, which is the trick valve that is CE marked. So these are the available therapies, transcatheter therapies for the tricuspid valve. And this paper by Fabienne Praz put very nicely the algorithm of treatment depending on anatomical and clinical characteristics. And we can spend some time to review this algorithm to understand which therapy is best for which anatomy. So we have now the TriClip and the Pascal devices that we're using for the transcatheter body-to-body repair, as I said, to the tricuspid valve. And we can assess here nicely the differences between the two. So the TriClip opens and closes very firmly. It's like a vice grip, so it doesn't allow for any movement once the clip is inside, and clips cleans very strongly. And on the other hand, we have the Pascal that is nitinol, so it has some elasticity and allows for some movement of the leaflets. So this is the Pascal generation 2 we're using now. And you can see that the other difference is that the retaining elements of the Pascal are all down here. So they're like a line of verbs here, whereas the retaining elements of the TriClip are along the grippers. So this is a small difference, a small detail that may make some differences on how they work. And these are the sizes of the different devices that we have now available. So you see here the small TriClip, the NT, it has a span of 20 millimeter. The large has a span of 25 millimeters, and this dimension is very important because it shows how much we can go behind the leaflet, how big the reach can be of these devices. And then for the Pascal is 26 millimeters, so 1 millimeter more for both of the devices. And then we have the width. The width for the TriClips is 4 or 6 millimeters for both the short and the long, 4 or 6 millimeters. And the width for the Pascal is 6 millimeters for the small and 10 millimeters for the large. The other difference is how much of leaflet they can get inside. So for the tricuspid valve, practically we only use the Pascal Ace and the TriClip, the XT, the big one. So if we can put them together, we see that we can get 10 millimeters of leaflet within the Pascal A's, but once the leaflet goes in, all the retaining elements, they grab it. And we can get up to 12 millimeters of leaflet in the XT, but how many barbs will be on the leaflet, it depends how deeply it will be inside. So if it's 6 millimeters in, it will get only 2 or 3 barbs. And what we have on clinical trials, we have the Triluminate pivotal trial that randomized 350 patients. At least this is the report on the 350 patients. In practically, they randomized, as you can see, much more patients, close to 300 patients, but this analysis is for the 350. They also had a single-arm cohort that they accepted patients that wouldn't be accepted in the randomized trial, so anatomies that they thought the result of the TEER wouldn't be perfect. So those patients, they accepted into a single arm. And this is the algorithm of the study. And you can see here that from the 1,500 patients, the 350 only got randomized. So this is a small percentage of patients. The other patients were excluded mainly of anatomical reasons, but some of them, 100, that they thought that they could have some procedure, they went into the single arm. So when we talk about this study, we shouldn't forget that only a small fraction, like 20% of the patients screened were actually randomized. This is very important. And these are the results. The results, there was no difference in the all-cause mortality between TEER and control. There was no difference in heart failure hospitalization. All the difference were in the quality of life improvement, more than 15 points improvement in KCCQ score. And you see here there's significantly more in the TEER arm than in the control arm. And this was a component of the endpoint. That's why the primary endpoint was positive. As you can see, the win ratio here, 50% more likely to have a better outcome if you have TEER than optimal medical therapy. And you can see here that we had like 88% success in the reduction of the TR with a Triclip to moderate or less. And all this with 2.2 clips per patient on average. So more than 2 clips, 88% reduction. But if we see the single arm, you remember those that they thought that the anatomy wouldn't be very good, perfect for TEER, and then you see a 10% drop in the success of moderate or less compared to the RCT study. And it's important also from this study, we saw that the more reduction we have in the TR, the better the improvement in the quality of life. So there was a mechanistic connection between the two, which is very important to see. And the number of patients you need to treat to get a patient alive and well more than the medical treatment is 3.5 patients to get one patient better. And on the other hand, we have the Pascal with the Triclasp study, the initial study, 6-month results, very similar, 88% improvement to moderate or less, exactly the same with the Triclip, but with less devices per patient, 1.75 as you can see. This is the respective study similar to the Triluminate, the CLASP 2 TR trial that is completed and will be reported soon with 800 patients randomized to Pascal and optimal medical therapy or optimal medical therapy alone. And we already have a report of the 3 first patients per site in the roll-in of this study. And we see here at 30 days, 74% had a TR moderate or less, which is considered a successful improvement in quality of life and symptoms with a mean number of devices 1.5. So there is a difference, less devices when you use Pascal than when you use Triclip. And if we get together with the randomized trial, all the registries we have, the BRIGHT, Triluminate registry, pivotal, we see that we have a consistent TR reduction across Triclip to 71 up to 88% moderate or less. And similarly, if we get the registries of the Pascal, you will see that similarly we get exactly the same number, 71 to 88% moderate or less. So good reduction with both technologies. And what is clear now is when we use these devices in the tricuspid valve, we always go for the larger ones. So you see in the bright registry, only the large triclips were used, XT and XTW. Similarly, in the PASTE registry with the Pascal, you see 93% of the cases, the Pascal ACE was used only. So it's very clear now what devices we use there. And as I explained earlier, it's very important for the tricuspid valve. Two things for the devices. First, how far away they go, the spanning of the device when it's fully open, and how much of leaflet you get inside. Another important issue for tricuspid TEER is the single leaflet device attachment that is much more frequent than in the mitral field. You see here in the bright registry, in the triluminate study, proportions 3.7 to 7%. This is a quite big problem when you have it. And similarly, with the Pascal device in the CLASP study, it was 4.8%. So it's easier to lose a leaflet in the tricuspid valve than in the mitral valve, and we have to remember that. What is complex or unfavorable morphology? A large gap size, certainly. TR that is not central or anteroseptal. Multiple leaflets, more than 3. Very large tricuspid annulus, large dimensions of the ventricle, of the atrium, torrential TR, tethered leaflets, and of course pacemaker leads. This is a gap, as you can see, it's a huge gap, so no device has the span to reach and to close this gap. Sometimes we can reduce this gap by prehabbing the patient, by diuresing the patient. You see an example of this here. It starts with a large gap, and after diuresis, this becomes much less and amenable to TEER. It's also important how we measure the gap. You can see there are many ways to measure the gap. Some are correct, some others are exaggerated. It's very important to remember, but by just tilting the patients, we change the fluid balance and distribution into the body, and we can reduce the dimensions of the gap by 25%, as we can see on average. This is important to remember. And from the screening from various literature, we can see that approximately 30% of the patients referred to us for TEER are rejected because of morphology, anatomy, or pacemaker leads. So 30% initially, they're just off. And then there is this study that they created, the TEER score. They take into account all these negative and disadvantages factors for TEER, and they created this score. So if the score is 6 or above, the possibility to have a very good result, it goes considerably down. And you can see that we have a very good discrimination by using this score, who will go well and who won't. So if we match together, if we add together the 30% of the initial rejection and the 20% that is not going to have a good result after applying this score, we understand that approximately 50% of the patients we are seeing today for TEER, it's good to be directed to another therapy, and that's why the TTVR is here, and probably that will be the final distribution between the two therapies, clipping and valve. It will be around 50-50 for these reasons. So this is an example of ours, but you can see a very large gap, very torrential regurgitation, and you can see this gap is close to 2 centimeters, so there's no way to get it done with TEER, and these patients should be screened for EVOQUE. And I will finish my presentation by just showing a procedure with TEER that we use 2 Pascal ACEs. You see a complex anatomy with regurgitation going from everywhere. The vena contracta is from anterior to posterior. You also see pacemaker lead that is in the posterior septal commissure, as you can see here. We have a gap that is less than 1 centimeter, as you can see here in the center. We don't believe that the pacemaker wire is responsible for this pathology, at least fully responsible. They may have a contribution. That's why we accepted this patient for the procedure. We knew that it would be challenging. So here is the first Pascal ace coming below the first clasping. It's easy. It's towards the anteroseptal commissura. We move more into the anteroseptal commissura here. We do the independent clasping here. You see the falling of the septal clasp. The lateral clasp is already in. Then we close the device, and we have a reduction of the collar from the area of that device. We knew that it would be a multiple device procedure, so this is the second Pascal ace coming, and just lateral, more posterior, and or towards the center, in comparison with the other one. Again, the independent clasping, first the lateral, and then here you see the falling of the septal clasp, and then we close the device, and this second device made the trick, and this is always the case. The more you go towards the center, the more the effect you have with the device. So we had a very good result with these two devices, and we accepted this minor mild TR for a very good result. And this is a procedure we used for the first time, the 4D ICE Accuson by Siemens, that we found very, very useful. And I'll just finish by showing you some images from 4D ICE. So initially, we went into the mitral valve just to have a look there, and you see how good imaging you can have by using the 4D ICE. We started with the mitral valve first. We had to do a clip there. That's why we crossed, but we did it with transesophageal. But this is the imaging we got. And I'm sure if we had the problems and we couldn't use transesophageal, we could use this imaging also for mitral clipping. So after finishing with the mitral clip, we went with the Pascal in the tricuspid valve. You see the imaging for the eyes, how nice it is, very clear imaging with the leaflets. So here the Pascal is below the leaflets, and you see the leaflets resting on the paddles, and then you see it is retracted upwards, and you see the falling of the clasps here, and then you'll see the closing of the device. We had to move it to a better position. That is the first device. If you remember, we moved more into the septal commissural, and this is the result with the first, and here is the second device, next to the other one, the closing of the device, and you'll appreciate that we had a very good result with these two devices without any interaction with a pacemaker lead, and this is the final result. 1 Pascal ace in the mitral valve, a concomitant treatment of both valves, and 2 Pascal aces in the tricuspid. And this is from another procedure in another patient, just to show you what kind of imaging you get from 4D ICE. You had a discussion about 4D ICE earlier, and I think it will be very useful in the future because it gives you the possibility to do tricuspid procedures without intubation and general anesthesia. You get this kind of imaging that is unbeatable and and very helpful. And with this, I would like to thank you for your attention.
Thank you, Kostas, for this excellent presentation. May I ask to Dr. Nikas what is his input on and his experience?
Good evening from Athens. This is really an amazing representation of what we can achieve today with the new devices we have in order to reduce tricuspid regurgitation. And I'm very happy to see that it's not anymore a forgotten valve. Actually, I don't ever believe that it was a forgotten valve, but we didn't have any tool in order to tackle this kind of disease. And we can see all these patients coming into our hospitals every week, every month, with this congestion, and we couldn't do anything else that give them diuretics. I think this is a very promising treatment for all of our patients. We have done a couple of cases in my hospital, and we've seen really good results. And my worry now is, Mihalis is sitting beside me, and I would like also to ask him which is the phenotype. Every week I'm checking the literature. Nowadays we can see different type of phenotypes in tricuspid regurgitation. And I would like to ask also Kostas, what is the preference, one device over the other in terms of phenotype, whether this is going to be an annular dilatation causing by, let's say, atrial fibrillation, or an annulus dilatation causing for RV failure? Is any device better than the other in this case? And is there any data comparing the two devices? What do you think?
Michael is here. Let's ask Michael first.
Yeah, that's a very good question. At this point, there's no data comparing TriClip to Pascal for treating tricuspid regurgitation with edge-to-edge repair. I think it's more of a preference depending on the operator and their familiarity with the devices. We could argue about one or the other, generally speaking, but I think it's more of a preference based on operator experience. For the fact about atrial functional TR, I think for atrial functional TR, usually we don't have that much tethering of the leaflets towards the ventricle. They sort of close at the level of the annulus. So technically speaking, they appear to be rather amenable to edge-to-edge repair. For ventricular functional TR, Dr. Spargias showed it very nicely. We have long, big gaps and very tethered leaflets, then things become very difficult sometimes. But in these patients now, we have the option of a valve, and we always have to really consider carefully whether we would proceed with edge-to-edge versus a valve. Because maybe moderate, leaving a moderate tricuspid regurgitation may not be the bar for success that we would like to see nowadays or moving forward. Thank you.
Yeah, I agree with Michael. My view is that we can get very good results with both devices. All the studies that I've shown to you and the registries demonstrate very, very similar success. So it depends on the experience of each center and of each operator. In our hands, we have a preference for Pascal, especially in the tricuspid valve. The reason is that because of its design, it's nitinol, it's much more forgiving for movements into the right heart, for movements under the leaflets, and because it elongates, and in the tricuspid valve, you very often need to come back and in again. So this elongation provides, I think, larger safety to do this device in the mitral valve. The other thing is that with Pascal, there is no limit to how many times you're going to open and close the device. You're not injuring the leaflets, especially the tricuspid leaflets that are very flimsy. With mitral clip, TriClip, every time you close it and you open it, you are more aggressive on the leaflet. So I don't think there is it's limitless how many times you're going to attempt on the leaflets. With Pascal, we don't have this problem. You can try many times. Now, the other thing, I think that the tricuspid valve is a very different animal from the other valves because the symptoms are very elusive, and you have to make clear that there's no other underlying pathology responsible for the symptoms. And many times when we see patients with advanced tricuspid regurgitation, this is just a sign of poor prognosis. And we have to be very careful when we decide to treat the tricuspid regurgitation first, that the etiology of the symptoms is this and nothing else. And second, that is not just a surrogate or indicator of bad prognosis, and in those cases, any intervention would be a futile tricuspid valve.
Kostas, on this, on the last topic you mentioned, could we imagine that you intervene before us, the surgeon, in a patient that is much in a better condition, and then doing the Pascal or TriClip, and then if things deteriorate because the regurg relapses or isn't completely done because of the annulus enlargement, doing it endoscopically, just inserting or implanting a ring and leaving in place the TriClip.
You're absolutely right, Aris, because if we do edge-to-edge repair and we fail for some reason, then we close the rod or we make the rod very treacherous for you to go and be successful in repairing, or for a transcatheter valve to go and implant it. So that's why now that we have available the transcatheter valve, and of course surgery is always available, we have to be careful when we select patients, and we shouldn't attempt on patients that the anatomy is unfavorable for success. So those patients, especially if they're younger, should be directed to surgery, no question about this. And if they're older, then we should think of transcatheter valve like EVOQUE first. Another therapy that I think is forgotten and underused is the transcatheter annuloplasty. The cardioband is out there for some years now. It's not very successful so far, but I think it's another good transcatheter option that leaves everything open for the future. So if the anatomy is good, to go with a cardioband and do transcatheter annuloplasty at an early stage. If it's successful, everybody's happy. If it's not very successful, nothing is like everything is available as an option in the future, both transcatheter and surgical. But I think that's why when we treat these patients, we need to be a heart team and discuss all these cases with you guys, the surgeons, that we have a lot of experience in the endoscopic, thoracoscopic repair, because you can also get very good results. So that's why we should be very careful when we select these patients.
Should we proceed with Dr. Rahul Sharma?